Hi everyone, shall we get started again? Yes, hopefully everyone's had adequate coffee, adequate pastries, fruit to get you through to the lunch break. So just to summarise how we're going to run for the next few sessions, lunch and networking will begin at 12:25. Between now and then, we have some excellent speakers. So first of all, Dr. Matthew Jenner is going to talk to us regarding tandem autologous transplant in high-risk newly diagnosed disease. Leading on from the previous debate, to be honest, whether this should be standard of care. So we all now know that autografting in general is standard of care. Sorry, Guy. But now we're going to talk about tandem autografting. Then we'll have some Q&A, and then we'll have our two ASH Abstract Award winners. So one of the important branches of the UKMS is that we provide bursaries every year to support travel and attendance at the major conferences around the globe. So at the spring meeting, we present the winners of the ASH bursaries, and we also provide bursaries for EHA and the IMS, which, as we all know, is taking place in Brazil this year, so every little will help. But in terms of Matthew Jenner, it's my pleasure to invite him to the stage. So he's a consultant haematologist at Southampton Hospital on the South Coast. He's also their clinical lead for haematology, oncology, and palliative care. He's a very active member of the UK Myeloma Society and also governance lead within the executive committee of the UKMRA. Matthew was co-CI on the MUC9 Optimum trial, so really we couldn't have a better speaker to talk about high-risk disease. And he's developing the next frontline study in the UK to follow on from myeloma 15, again in combination with Martin Kaiser for transplant-eligible myeloma patients. And he's also the author of upcoming BCSH guidelines on treatment of relapsed multiple myeloma. So Matthew, thank you very much for joining us.
Thank you very much, Kerry, and thank you for giving me the opportunity to talk today about tandem transplants. So I'll just spend a few moments just defining high-risk myeloma in terms of shaping the question. I will spend a little bit of time just going through the history of tandem transplants in myeloma, just to really, for us all to understand how we've got to where we are at the moment. We'll discuss some of the evidence and a little bit of real-world data, and then touch upon alternatives at the end. So broadly speaking, when we're looking at high-risk disease, there's kind of clinical risk and then there's biological risk. Clinical risk in terms of presentation, you'll be very familiar with in terms of presenting with plasma cell leukemia. The traditional definition of 20% plasma cells, of course, has now been replaced with a 5% definition, but there's a very high correlation with 17p deletion, but also interestingly, the 11-14 translocation, which generally isn't regarded as high risk in the non-plasma cell leukemia setting. If you look at data, it obviously varies hugely from retrospective analyses, but some early studies showing an overall survival of only 6 to 12 months, and even with an auto, only maybe around 2 to 3 years. Then there's another concept of what we term extramedullary disease, and just to make that distinction between true extramedullary disease in terms of soft tissue disease, lumpy disease, for want of a better word, in the liver, lymph nodes, kidneys, for example, not paramedullary, which is associated with bones. Again, variable incidence between about 0.5% and 5%, and that is typically associated with the classical high-risk genetic abnormalities. Very variable outcomes because it's not kind of consistently recorded across clinical trials, but hazard ratios in some studies are around 3, so 3 times higher chance of progression and death compared with no extramedullary disease. And then, of course, I won't go into all of these, but you're all very familiar with the other clinical features that all confer for worse outcome in terms of renal impairment, LDH, ISS, and, of course, age and frailty, which I'm not going to touch upon today, but you heard a little bit about earlier on in discussions of fitness or otherwise for autologous stem cell transplant. From an international perspective, traditionally, most studies have only looked at 3 abnormalities, the two commonest adverse IGH translocations in terms of 414 and 1416, and then deletion of 17p, combined, of course, with ISS, and now the revised 2 ISS. Whereas from the UK perspective, we've looked for some years, going back to myeloma 9, actually, at 6 different abnormalities, so 3 IGH translocations, 414, 1416, and 1420, and then deletion of 17p plus also deletion of 1p and gain of 1q. And you'll have seen all these slides before in various presentations over the years, but what's very clear is that the individual lesions are important, but actually it's the combination of lesions that's increasingly important. And there is, of course, overlap between those different lesions with the cross-section at the bottom, as you can see in the Venn diagram. And data from both myeloma 9 and myeloma 11 has been able to demonstrate that the overall survival is worse the more abnormalities you have, whether you have none, one, or two or more abnormalities. So just to go back to the question, which is what is the role of autologous stem cell transplant, and particularly tandem transplant in high-risk disease, I think it's worth refreshing our memories as to what we're actually talking about. We're talking about a really toxic drug, and you've heard the debate just before coffee around melphalan and its side effects. You know, it's been around a long time. It's, of course, derived from mustard gas, and it is, therefore, a true poison in that sense of the word. First used, of course, orally in the 1960s, but at higher doses, as I'll show you in a moment, into the 80s and 90s. There's a clear dose-response effect of melphalan, so the higher the dose, the higher the response, but it damages cells, it damages DNA by cross-linking, and that's how it works in terms of its anti-myeloma effect, but of course that's also how it causes some of the longer-term toxicities, such as secondary AML and MDS. So just to recap some more history, if you saw some of this earlier as well, first used intravenously in the 1980s, and actually really heralded quite unprecedented responses in both newly diagnosed and relapsed disease at doses at that stage of 100 to 140 milligrams per meter squared. And all of those patients responded to treatment, including 3 of 5 who'd previously, 3 of the untreated patients who actually achieved a complete response. The first larger study was in the late 80s with 58 patients, 41 newly diagnosed, again using 140 milligrams per meter squared with no stem cell rescue, but again achieving very high responses with a quarter having complete and half having partial responses. But of course, all the side effects that we're very familiar with using high dose of melphalan. And importantly, in this study, 10 deaths with a mortality rate of 17%, which clearly we wouldn't tolerate nowadays, and also a very prolonged time before blood count recovery. Many studies, and I'm just going to cherry pick studies, but of course this was the MRC myeloma 7 study, which really demonstrated the benefit of autologous transplant compared with standard of care, and showing roughly a 12-month improvement in survival compared with non-intensive chemotherapy options. And there have been many other studies that have shown similar things, including the more recent ones presented before coffee, using comparisons against RVD. However, at the same time as in the UK, we were comparing no transplant versus transplant. In Europe, they were actually looking at the role of tandem transplants. So the IFM looked at nearly 400 patients and compared a slightly different regimen to that which we use nowadays of melphalan with TBI versus a tandem transplant of melphalan 140, first of all, followed by melphalan TBI. And again, a cutoff of 60 years of age, as is the case of many of these early transplant studies. But that study was the first one to show clearly that there was a benefit of tandem transplant, both in terms of progression-free and overall survival. The Italians undertook a similar study 2 or 3 years later, just over 300 patients, again under 60. They used melphalan 200, so much more similar to that which we use today, but the tandem transplant was slightly different. It was that the second transplant was melphalan 120 with busulfan as well. And that study was interesting because it did show the progression-free survival advantage of the tandem transplant, but actually showed no advantage in terms of overall survival. And actually, it's very much the rationale, therefore, for us pursuing, as has been traditionally the case in the UK, a deferred second autologous stem cell transplant. And that evidence, of course, was demonstrated in the myeloma 10 study, showing the benefit of second transplant in the deferred setting as opposed to in the upfront tandem perspective. And that, I guess, is where a long time before Brexit, but the UK and Europe possibly diverged a little bit in the sense that we, traditionally in the UK, have almost entirely stuck with a single transplant and then reserved the second transplant for progression, whereas in some European countries, there's been more of a tendency to pursue this data and stick with upfront tandem transplants. So what about high-risk disease, which of course is the point of this discussion today? I'm going to present 2 studies which initially look to be conflicting, but actually with longer follow-up, maybe the data is is more uniform, and then some real-world data as well. So the EMN02 HOVON 95 study was one of the studies that actually demonstrated the potential benefit of transplant versus no transplant, using, obviously, at the time, a more conventional induction of VCD, and patients were randomized to either have VMP or a single or a tandem transplant. I'll come back to that in a second, followed by consolidation and maintenance lenalidomide. In those centres, and because centres varied their standard of policy at that stage, it was a one-to-one randomisation between VMP and auto, and those where the standard approach was to do a tandem transplant, there was a three-way equally split randomisation between VMP, single auto, and tandem auto, as shown on this next slide. So this specific analysis was the 400 and something patients who had either a single auto or a tandem auto. And what this data demonstrates was that at the 3-year time point, the difference between a single auto and a tandem auto was there, with the progression-free survival at 3 years increasing from 64% to 72%, but still relatively modest and actually only just meeting statistical significance. However, when you look at the data by genetic group, and in this study they looked at the 3 classical high-risk abnormalities, 414, 14, 16, and 17p deletion, there was a much more marked difference in progression-free survival in those patients who had high-risk genetics, with the 3-year PFS increasing from 44 to 69%, and actually the overall survival also meeting significance, increasing from 72% to 84% at 3 years. So this data very much supported the concept of offering tandem autologous stem cell transplants in the high-risk population defined by genetics. Lots of discussion have taken place since then about actually, are there other predictive factors that might inform your decision-making about doing the tandem transplant, including what the potential role of MRD is. And just discussing with some of my colleagues yesterday, some people are using that to inform. And unfortunately, within the EMN02 study, whilst there was MRD assessment, it wasn't looked at in relation to that second question about single versus tandem transplant. So this slide simply demonstrates what we all know, and you've seen many times over, in terms of whatever treatment you have, if you get MRD negativity, you're clearly going to do better in terms of PFS and OS. But this second set of curves is quite interesting, and you can see at the top, and it's not huge, but you can see at the top, those patients in the 2 lines at the top are those patients who achieved MRD negativity by whichever route, whether they had a transplant or no transplant. They did basically the same. What's quite interesting, if you look at the bottom curves here, is actually there was a difference in those who actually failed to achieve MRD negativity. In other words, if you didn't achieve MRD negativity, you actually did significantly better with a transplant. And it probably demonstrates that, therefore, a bit like Kerry was saying earlier, you're offering additional treatment on top. So if your standard treatment hasn't got that response, you offer the transplant, you're getting more depth of response. Important to stress, however, that this, of course, is the evidence for transplant versus no transplant, not the evidence for tandem transplant or single transplant, because that unfortunately is not there. So we just got to extrapolate based on this data. The other study that was published and presented around the same time as the EMN02 data was the US Stamina study, and did initially indicate slightly different results. So this was an all-comer study that did not stipulate what induction people had, and people could have had up to about 12 cycles, I think, of induction at that stage. Patients were randomized to receive a single transplant followed by either lenalidomide maintenance, RVD consolidation followed by lenalidomide maintenance, or a tandem transplant followed by lenalidomide maintenance. And the colours on here, the 2 blues, are worth looking out for on the next curves, as well as a yellow, which is the tandem transplant arm. And this is actually extended follow-up presented in 2020, and you can see without looking at the numbers that essentially the curves are all overlying each other. So one might argue that this was effectively the sort of the death knell of tandem transplants, because actually pretty much showing that there's no difference if you look at the whole data set. However, if you do look, and this is now at 5 and 6 year follow-up, if you do look at the outcomes associated with those who have high-risk genetics, who actually did go on to receive a tandem transplant. So that's an important bias introduced in this analysis, because it's on a per protocol, on a received basis rather than on an intention to treat basis. You can see there's quite a significant difference appearing in the high-risk patients in terms of the yellow curves here and the tandem auto versus either RVD or maintenance, and starting to reach statistical significance with a PFS of 43 months versus 37 and 32 months. So again, I think this is supportive data indicating the potential role for tandem autologous stem cell transplant in the genetically defined high-risk group. Importantly, though, no survival advantage at the present moment in time, and that is potentially relevant. How about the real world? Actually, clinical trial data is all well and good, but we know that there's intrinsic biases within clinical trials in terms of patient selection and so on. There's also, of course, intrinsic biases with real world, so we have to take both to a degree with a pinch of salt. But the EBMT undertook an analysis of two specific subgroups, 17p deleted myeloma and 414 myeloma, from the EBMT registry. So over 600 patients met those criteria of either having 414 or 17p deletion or both. So it did not include 14-16 translocation, of which over 400 had an single auto, 100 had a tandem auto, and actually 72 had an auto followed by an allograft. Time era is important, of course, with all these things. This is between 2000 and 2015, so before the advent of monoclonal antibodies routinely. Median age of 59, so that slightly younger population. It's black and white, unfortunately, so it doesn't present all that well, but just walking through all of this, you can see here that this is the landmark analysis from transplant, or from first transplant, looking first of all at the overall survival on the left here and progression-free survival on the right. And you can see that the 5-year overall survival for the single auto was 51%, 60% for the auto, and 67% for the auto-allo group, not reaching statistical significance. However, the progression-free survival was significantly different, with only a 5-year progression-free survival of 17% in the single auto arm alone, 33% in the auto, and 34% in the auto-allo group. So I think this does demonstrate that some kind of second transplant, and we won't go into the allo debate today, but some kind of second transplant, be it auto, or auto-allo, does appear to confer certainly a PFS advantage in this 414, 17p deleted group as well. So that's a large data set from across Europe. We looked at our own data, presented this 3 years ago at BSH, looking at our own data over nearly 20 years in Southampton, with over 650 patients, of which we had FISH testing in just under half of those cases, and actually we were able to analyse them by the full 6 abnormalities, so the 3 IGH translocations, deletion 1p, gain of 1q, and deletion of 17p. This is just all comers with any form of transplant, really identifying what we know already, but actually this is real-world data demonstrating that the more high-risk abnormalities you have, the worse you do. PFS is maybe less dramatic, but you can see on the left here that whether you have 0 or 1 abnormality, it's actually quite similar with a PFS of just over 3 years. If you have 2 or more abnormalities, the PFS is actually less than 2 years. I think most dramatic, and I think it's really informative, just in terms of thinking about patients that we see and treat every day in the clinic, is the outcome associated with having, the overall survival outcome associated with having 0, 1, or 2 or more high-risk abnormalities, with an overall survival of 11 years if you have no high-risk FISH, to just under 8 years if you have 1, to having only an overall survival of 3 years if you have 2 or more high-risk abnormalities. Now, of course, we need to bear in mind the time period we're talking about, from the early 2000s until pre-2020, in terms of the other treatment options available to us at that stage. But I think really quite compelling to say that we should not just be doing same as in this patient population, particularly those with 2 or more high-risk abnormalities. Now, this initial analysis, as I say, took place in 2021. So we did try and look at our tandem auto data at that stage. We only done 12 at that stage, so probably not enough, maybe a suggestion, possibly slight improvement, but I think too early to tell. as I say, small numbers. Key differences in terms of what we were doing then in 2020 versus what we're doing now is, of course, very different heterogeneous induction regimens over the last 20 years. Unlike the EMN02 study, we have generally gone for offering tandem transplants in those with 2 or more high-risk abnormalities based on that data showing the really very dire outcomes associated with 2 abnormalities, potentially 17p deletion as its sole abnormality as well. Of course, at that stage, most patients did not have access to lenalidomide maintenance. They do now, but the first era that we looked at there, that was not the case. And actually in the EMN02 study, they did have lenalidomide maintenance, as they did indeed in the Stamina study. We just started a further analysis of the last 3 years, so from beginning of 2020, the end of 2022. We did something like 260 autologous transplants in that time, of which 47 we considered for tandem. And I think this possibly is a debating point later on, because I know, again, speaking to other colleagues, the suggestion is that the conversion rate from doing a single to a tandem is quite low. Actually, in our hands, it's actually 80%. So 38 of the 40 that we planned to do a tandem, we did do a tandem in. Of those that didn't proceed, 5 were for patient or clinician choice, so mostly around toxicity. 2 patients did actually progress in the gap, and that's indicative of that patient population, really high-risk disease, and there was actually 1 transplant-related mortality. But I think it does demonstrate that actually it is very deliverable as a treatment in the current era as well. How about alternatives? Well, just to paint the other side of the picture, as it were, there's certainly very, very effective alternative regimens now available. If we look at 3 different studies, the first is a GMG concept trial, where they've combined a 4-drug induction of a monoclonal antibody, highly effective PI in the form of carfilzomib, lenalidomide and dex for newly diagnosed high-risk myeloma, 6 cycles of ISA-KRD. There was actually a non-transplant arm that I won't go into, but the transplant arm, 99 patients, went on to have an auto, followed by 4 cycles of ISA-KRD and then long-term ISA-KR maintenance. Very, very high response rates achieved using this approach, both end of induction but also post-transplant and then, of course, post-consolidation, and very impressive progression-free and overall survival with 3-year progression-free survival around the 75% mark and high rates of MRD negativity. Second study, which is just summarised briefly here, which is the French IFM 2018-04 study. Similar approach, actually using a 4-drug induction, DARA-KRD. But interestingly, in this study, they actually used a tandem transplant, dropping in the middle of the tandem transplants in the gap, as it were, consolidation in the gap rather than consolidation post-transplant, as it were, and then going on to Len-Dara maintenance for 2 years, again with really high response rates and progression-free survival at the 30-month time point of around 80%. And then, of course, actually, Rakesh presented this morning already, so I won't go into all of this, but then there's, of course, our own Optimum MUC9 study with 107 patients stratified as high risk on the basis of slightly different criteria, important to be aware of that, using a combination of either conventional genetics, so 2 or more high-risk abnormalities, and or gene expression high risk to identify ultra-high-risk patients, and also, and importantly, including plasma cell leukemia, which is often excluded from many clinical trials, but we know how poorly those patients do perform. And using a digital comparison rather than a randomized comparison between the 5-drug and prolonged consolidation maintenance schedule with myeloma 11. And as I say, you've seen these curves already, so I'll go through these relatively quickly, but at the 30-month time point showing a really, I think, pretty remarkable improvement in 30-month progression-free survival from 40 months up to 77, 40% up to 77% with Optimum MUC9. And even if you compare against the best arm within myeloma 11, which is the KCRD arm, increasing from 49% to 77%. And at this stage, at 30 months, a significant overall survival advantage from 73 to 83%. And we're hoping to re-look at both the PFS, but importantly, the overall survival data later on this year. And hopefully we'll have even more compelling evidence at that stage. So really just to finish off, what about other treatments? I'm not going to go into detail about other treatments today, like T-cell engagers and CAR T-cell therapy, because you'll be hearing more about that later on from Niels. But there's certainly encouraging data regarding T-cell engagers and high-risk disease. It's fair to say that the data probably is indicating there is a slightly differential response, in particular with extramedullary disease, maybe with high-risk fish, in terms of maybe not quite as deep responses, but it is a different population. It is a relapse refractory population, and you can't always directly compare that situation with newly diagnosed disease. So I think there's still a huge amount of promise for T-cell engagers in newly diagnosed myeloma. And then similarly for CAR T-cell therapy, it's a long way, I think, from the UK being able to routinely access CAR T-cell therapy, but the data remains relatively limited still at the moment. So to summarise, I think there's some reasonably good clinical trial data in support of tandem autologous stem cell transplants in newly diagnosed high-risk myeloma. There is some real-world data available as well, but not as much as perhaps there might be. I think it's fair to say it'd be interesting to hear others' views about that, but there's fairly mixed uptake across the UK in terms of tandem transplants. It is in the frontline newly diagnosed myeloma BSH guidelines, but I think there is quite variable practice across the country. We don't really know what the impact is of the current treatments, and by that I mean Dara-VTD, because actually all these studies were undertaken, of course, before the Dara-VTD era. And there's clearly very, very good data for the benefits of using multi-agent combination chemotherapy, whether that be Dara-KRD, Dara-CVRD, but particularly prolonged consolidation, I think is probably as important as the induction treatment. Different studies use tandem or not, so MUC9 and GMG Concept do not use a tandem, whereas the IFM 2018-04 did use a tandem. So I think the jury is probably still going to be out for a little bit of time, and I think whilst those options look very, very attractive, right now today in the UK we can't actually deliver 5-drug induction on the NHS and 18 months of consolidation. I think tandem autologous stem cell transplant is actually achievable option for that high-risk population of patients. And then finally, of course, what we really also need and want to know going forward, and we'll get some initial results when the radar amendment opens for the high-risk arm, is what the roles of some of those newer therapies, particularly T-cell engagers, is going to be in terms of the impact in the longer term in the outcome of high-risk myeloma. Thank you.
Thanks, Matt, for such a great talk. Perhaps I could invite all the speakers from this morning to come and join us and be part of the panel for questions now. And if you've got any questions specifically on tandem, you can ask those now. If you're online, please do ask your questions in the Q&A function. And while we're waiting for everyone to come up, we can see if there are any. I'm going to vacate my seat to. Queer, yes, go ahead.
Someone else was first over there. Yes.
Just waiting for Matthew to get seated. I think a comment and a question. The identification of high risk at the point of diagnosis, of course, is the majority of people who relapse early post-auto are not identified by that risk score. So there's a whole load of high-risk patients who we don't know about at the point of diagnosis. In fact, more than we do know about. The other question is that we lump the high-risk genetics together, but you don't become high-risk by the same mechanism. So, for instance, I haven't really seen P53 malfunction as a single entity, because one may well argue that giving them DNA-damaging drugs is exactly what you shouldn't be doing, in that you're just going to create a P53 clonal selection. So are you aware of the P53 in isolation about more intensive DNA-damaging agents?
So just kind of answering your comment and then the question. So I think the issue regarding not prospectively identifying all the patients, I think, is twofold. I think traditionally fish testing results in terms of the success rate has been not as good as it might be. I think through radar, we've been able to see and hopefully improve across the UK the hit rate to getting it much closer to 80% of actually getting a valid result. So if you look at some of the retrospective analyses, including from trials like myeloma 11, obviously Kerry's worked on looking at early relapses. A lot of it's because the data just wasn't available, as opposed to because they were normal fish.
Yeah, it's not just myeloma 11, though, is it?
But I think it's because the testing isn't there. But then the second part, of course, is using other modalities, which is gene expression profiling. And so just the Venn diagram showed earlier, there's a group who are gene expression only high risk, and then those are genetically, conventional genetic high risk, and obviously the overlap between the two. And that's we're just looking at that within MUC9 as to what the differences are in those outcomes. So there is a group who are not identified by conventional genetics that may well be identified by gene expression profiling, or indeed other novel techniques going forward. And I think we're probably better at identifying them in the future, maybe not today, but in the next few years, I think we're better at identifying those patients. In answer to the 17p question, I think it's a really, really interesting question, and certainly I was very concerned, if we go back 10 years when we started designing MUC9, about the risk of clonal evolution and genomic instability with 17p deletion, but also actually the other, 414, if you look at the genomic makeup, it's often multiple abnormalities, really quite complicated. And actually the data doesn't support that, because actually by giving, admittedly, a single transplant in MUC9 but prolonged treatment, you're actually able to, at least for a period of time, switch off, those clones. I'm sure in the fullness of time they will come back.
I've not seen the 17p data in isolation. It's always just lumped in with the others. Can you comment on that?
So I think, we're looking at that again, part of MUC9, and looking at the subgroups within that. So I think we'll have a better idea over the next 12 months when we've been able to do that analysis.
Thanks. Kui.
Thank you. Yes, as usual, my question is much simpler than Jamie's insightful questions. This is about exposure to 2 doses of high-dose melphalan. Can you talk a little bit about any concerns and worries about mutagenic effects and whether these are really borne out in real practice, in experience?
Do you mean within the myeloma clone or the AML type risk, or both?
Both.
Both.
I think AML really, because I think the myeloma clone is probably been addressed by,
I mean, I think we're talking about an ultra-high-risk group of patients who, based on our original, the data, our own data from Southampton, you've got an overall survival of 3 years if you do a single transplant. Now, that's obviously historical data and doesn't take account of some newer therapies, but I think it's a bit like the argument for LEN maintenance, and the risk of second primary malignancies. Actually, if the benefit exceeds the risk, then on balance, I think it's still something that should be explored, because unfortunately, most patients with high-risk disease are going to die of their myeloma. Of course, there's going to be a very occasional person who gets secondary MDS-AML, and you need to make sure we counsel patients appropriately.
Thank you. And just as an extension, I think Curly has a question, but what about the effect on the myeloma plasma cells? Because I think the Dana-Farber group has shown an increased incidence of mutations. Do you think that's a real worry?
I think it is a worry, which is why ultimately I don't think we should be doing tandem autos, and I think we should be offering some form of prolonged consolidation and maintenance, or indeed some of these other novel therapies that we don't know what the outcomes are of yet. So I think right now, because we can do it, I think that's where tandem auto sits. I think maybe 5 years' time we'll be doing something different.
Thank you.
Just while Quee's got the microphone, actually, we've got a question from online, so perhaps we can have a combination answer, but someone's asked, was the consideration of tandem in the radar study? And will it make it in? Did it have a chance of getting in before?
Did we consider tandem transplant
in the high-risk patients?
In the high-risk patients in the radar study? I guess we did, but at the time we were concerned more to, so in terms of risk stratification as a start in the radar study, the consensus was that we would address the high-risk patients by intensifying post-ASCT treatment in terms of combination consolidation regimens, which is where I think Matt was going in terms of alternatives to a second transplant. So I guess a cool randomization might have been to a second transplant or an intensive combination consolidation regimen. But I think it was all down to numbers and stats. But maybe Matt could comment on that. Do you think if you were to select the optimum consolidation regimen to study against the second transplant, what might that be?
I think in terms of conventional therapies, then, as in not including bispecifics and CAR-T, then I think the multi-drug IMiD PI monoclonal antibody combination it seems to me to be the obvious one, but it's a prolongation. I think the time is also important as well. So I know some studies had 4 cycles, but I do think a long time is needed. How long? Of course, it might be compared 6 months versus 12 months versus 2 years, something like that, but I don't know how viable that would be.
And a bispecific?
Sorry?
And a bispecific antibody, would that be?
Yes, so that's using conventional, then absolutely. I think it's really important to look at bispecifics to see what impact they have in this newly diagnosed setting, because I think they're probably going to have better chance of overcoming things than the relapse refractory who's clearly got multiple genomic abnormalities.
Thank you.
Okay, any more questions in the room?
I have a question. Question for Matt. So in MUC9, you added Velcade to melphalan as part of the conditioning. Can you just walk us through the rationale for that? And are there any other things that you could do around a standard auto to enhance the effectiveness?
Yeah, so the melphalan Velcade came from those French studies, Japanese studies, again going back 10 years, which was just using either 2 or 4 doses at the time of Velcade. And actually, the more recent studies showed that probably 2 or 4 doses doesn't make a huge amount of difference. However, what we know also with ultra-high-risk disease is that relapse in the first 3 months is real. Again, just our own data from Southampton, we had 2 patients relapse in the first 3 months in between tandem autos, essentially. And so the idea of the weekly Velcade, which is given right the way through to day 100, was to try and prevent that early progression in a reasonably non-toxic way before you actually introduce combination consolidation again, which is probably too much in terms of bone marrow reserve to induce lenalidomide and daratumumab too early.
So it's more limited early consolidation?
Yes.
Yeah.
So thank you so much for all the great talks. I have a very kind of practical question also about tandem transplant in high-risk patients. So, of course, we expect that the benefit from the transplant comes by deepening the disease response and prolonging kind of long-term disease control. And, of course, there's, I think, some post-hoc analysis showing that if you have like a suboptimal response, so less than VGPR-CR, following the first transplant, the sequential transplant probably kind of deliver a higher benefit. I just want to understand, so when will be the optimal timing for the second transplant, and how do you use, let's say, the first transplant disease response in kinetics really to assess the importance of the second transplant? And by asking this, I'm mainly kind of doing a reference for those patients who you don't see an improvement in the disease response following a first transplant. So can we consider this type of disease really a kind of chemo-resistant type of disease? Therefore, even though if they are not in an optimal response following first transplant, a second transplant will not be the way to go.
I think it's a really, really, really good question, because actually how should we use response assessment in between the two? And I think the main problem is I don't think there's any data to really inform us at the moment. So it's absolutely a question of judgment. And I think that point of someone who has not achieved there's a balance, of course, because some of those early tandem studies, and I didn't go into that today, show exactly as you said, that if you've still got residual disease, there's a benefit of doing it. But if you've had no response at all between your end of induction and your transplant, what is the outcome? So I think that is absolutely an area that warrants further analysis, even if it's only retrospective analysis rather than randomised. I think it's going to be very difficult to do a randomised study of tandem autologous transplants in the current era. I don't think it will happen. So I think the only way we're going to know is through retrospective analysis. My current practice is, because of the data that exists, both from the EMN02 study and the Stamina study, is to not use that. If someone's progressed, obviously that's different, but it's actually, I don't take account of that at the moment.
So just to be clear then, if a patient was MRD, you wouldn't know they were MRD negative in between the transplants, but if they were to be, they would still go on and get the tandem transplant.
I think so. It's the iceberg thing. So how far below the iceberg are you going?
And I think it's also, are you committed to a tandem because there's a body of evidence to say it benefits the group as a whole, or are you looking to show melphalan sensitivity? And I think if you go with option 2, then you would perhaps do more what the speaker suggests. But everything Matt said is that in the absence of enhanced consolidation and maintenance, we don't really have much else to offer these people that can show any kind of survival benefit.
So on the, we've had lots of interest in tandem. On there, I'm going to ask the speakers for practical their opinion. So going along then, if we could all just say what you do now with a 70-year-old standard risk patient, would you put them down there, without knowing any of the details, would you put them down the DVTD auto transplant pathway, or would you go for a non-transplant pathway? And can you add to your answer whether you would change that in the presence of a high-risk genetic abnormality? Start with Kerry.
So if they had a good performance status, I put them in radar.
Okay. Let's say once radar accrues and it's closed.
Again, if they had a good performance status, I would offer them DARA-VTD pathway. If they had high-risk genetics, again, in the absence of anything else to support them around the auto, then I would have a discussion about tandem.
Okay. Matt?
Yeah, probably a very similar answer. I think the one thing that we don't have at the moment, though, is maintenance daratumumab, which obviously you're effectively getting with DRD, and it's a really difficult one. So do you want to get the kind of the better early response with the DARA-VTD in the auto, which is, I'm sure you're probably going to get, but then you're committed to giving them LEN maintenance, which is okay, but it's not great in ultra-high-risk disease, or do you want to be able to give them effectively LEN-DARA maintenance? And I actually don't know at the moment. I'm very much debating that myself as to what the best approach is for your high-risk, slightly older population. I think I would still give strong consideration doing a tandem. I mean, I didn't show our age range, but we've done tandems into the 70s as well.
And in the standard risk patient, what pathway would you put them down?
I would very much go on patient preference. I would actually go through both sides of the coin in terms of the short-term toxicity, which clearly is there with autologous stem cell transplant. We talk about day unit visit, talk about the whole thing and actually see what someone's perspective is. And I think it is very much an individualised approach.
Kirsty?
Patient is fit, comes down to my fitness assessment, then definitely I'll go down that transplant pathway.
Transplant pathway for 70-year-old standard risk. Guy?
I discussed it with a patient, and the last patient I discussed it with wanted DRD, interestingly. Personal preference, I probably would go down the transplant route, but it's very much an individual decision, I think, with a patient.
And in the high-risk group, presumably you'd opt for a transplant?
I think a transplant is probably preferable in that group if you had those results to hand.
That's the key, isn't it? Having those results. Often we're making these decisions in the absence of the fish. It's only patients who've been diagnosed and perhaps monitored through a smouldering phase that you have the luxury of having that information up front.
And we're in the unfortunate position that once you start off down one of these pathways, it's difficult to do any sort of changes, isn't it? Which I'm sure many of us have found ourselves in. Okay, I think we've answered all our online questions and can't see any more in the room. So should we give another thanks to our speakers? It's been brilliant. We're going to move on to the next section now, just before lunch. So we're going to be hearing from our ASH abstract winners. First of all, I'm going to invite up Dr. Yakinthi Chrysokoidou. Yakinthi was awarded BSc in Biological Applications Technology at the University of Ioannina in Greece in 2015, subsequently an MRes in Biomedical Sciences and Translational Medicine at the University of Liverpool, went to Imperial College for a PhD looking at mechanisms producing fibrosis around mesothelioma, and she then joined the Institute for Cancer Research, working on intrinsic and extrinsic mechanisms of IMiD resistance in multiple myeloma, and she's going to introduce her talk now.
Hi everyone, thank you for the introduction. I will be speaking to you today about our project investigating the impact of cereblon mutations on response to IMiD and CELMoD agents in myeloma. So we all know our immunomodulatory drugs, or IMiDs. They are a standard of care at all lines of myeloma therapy, used in combination therapies at multiple stages of the disease, and also as a single agent maintenance therapy. We have our IMiDs that are currently used in the clinic, lenalidomide and pomalidomide, and then we have the next generation IMiDs, also referred to as CELMoDs, iberdomide and mezigdomide, which are currently in clinical trials. These compounds all function in myeloma through the same mechanism of action. IMiDs target cereblon, the substrate receptor of the CAL4E3 ubiquitin ligase, and when cereblon is bound by IMiDs, its substrate specificity is altered, leading to ubiquitination and degradation of new substrates, including transcription factors Icarus and Aiolos, which in turn result in downregulation of IRF4, a key transcription factor in the survival of plasma cells. Through sequencing of patient biopsy samples, we and others have discovered that post-IMiD treatment, approximately 1/3 of patients presents with genetic alterations in cereblon. And while it might be easier to predict the effects of whole exon splicing or copy loss in cereblon activity, the functional effects of the missense mutation are less predictable. And as sequencing panels become more widely available as part of myeloma patient diagnostics, it's of increasing importance to understand the functional impact of any mutations identified, so we sought out to investigate these missense mutations functionally. So, from every publication that recorded cereblon mutations in patient datasets post-IMiD treatment, we identified 34 mutations, those highlighted up at the top. And from those, any frame shift or stop codon mutations that naturally result in non-functional cereblon have been excluded. Then we selected 11 missense mutations for further investigation, deliberately choosing mutations spread through the entirety of cereblon. On the left, you can see how they line up through the entirety of cereblon. There are some in the lone binding domain, this blue segment where cereblon interacts with another protein in the E3 ligase complex, DDB1. And in the purple here, we see the mutations located in the thalidomide binding domain, where the drug actually binds. And within that, we have zinc ion binding sites highlighted in teal. And in red, we have the beta hairpin sensor loop that mediates cereblon switch between open and closed conformation. On the right, you can see here each mutation mapped in cereblon. These are the mutations mapped in pink, and the teal molecule up there is lenalidomide. So we sought out to investigate the impact of each one of these mutations. The first step was to generate a cereblon knockout model, meaning a cell line that does not express the protein. So we started with MM1S, an inherently IMiD-sensitive cell line. Those cells responded to treatment, and then we CRISPR'd out cereblon. 2 cell lines were generated, and you can see they're highlighted here in red and blue. And as you can see, these cell lines do not respond to treatment, both to IMiDs and CELMoDs. And of course, we lose all the downstream effect. We don't see degradation of the neosubstrates or downregulation of IRF4 and cell death. And then next, these cereblon knockout cells were transduced with a plasmid expressing cereblon, but each one had a point mutation, mimicking the amino acid chains that is observed in patients. And the first observation is that reintroducing cereblon back into the cells does result in cell death, and the cells are resensitized to IMiDs. So after that, we aim to understand which missense mutations are deleterious to cereblon function and whether any mutations are associated with the differential response between IMiDs and CELMoDs. This was done through 2 types of experiments aimed at ascertaining the cell's viability response to our IMiDs and CELMoDs, and then functional validation for each mutated cereblon to observe its activity. This heat map consolidates the results of 240 cell viability assays across all cell lines with cereblon re-expression for each mutation against IMiDs len and pom and CELMoDs iber and mezi, and the viability responses match the neosubstrate degradation results shown by Western blot, and I'll be showing you examples of those going forward. But we can clearly see that the viability responses are divided into 3 major categories. First, we have the mutations that do not alter cereblon function. These behave like re-expressing wild-type cereblon, and you can see here in the heat map where cereblon is highlighted, there is a proper reduction in cell viability as expected, both to IMiDs and cell modes, and matching that, we have degradation of neosubstrates and downregulation of IR4. I've highlighted all the mutations that behave just like in this manner, just like wild-type cereblon, and we can see that most of them are located in the lone binding domain, and surprisingly, even mutations in the thalidomide binding domain, here and here, they can't be tolerated as long as they do not disturb the folding or stability of cereblon. These do not appear to alter the structure in any way enough to result to IMiD and cell mode resistance, so they are tolerated to result in a functional cereblon and response to treatment. The second category are mutations that completely abolish cereblon function across all drugs, both IMiDs and cell modes. As you can see here in the heat map, or negative control containing only an empty vector. This response is all red values. Accordingly, there is no reduction in cell viability, and there is no degradation response or cell death. And in this category, we have our positive control mutation here, mutating this tryptophan. That is a part of a tritryptophan pocket. That's the exact spot where IMiDs bind within the thalidomide binding domain. And mutation of any one of these molecules leads to structure collapse and non-functional cereblon. In this category, we also have one additional mutation at position 397, and mutation of this histidine at position 397 into a bulkier tyrosine cannot be spatially accommodated and is also predicted to lead to a complete collapse of the tritryptophan pocket, as seen here, which would prevent any IMiD or cell mode binding. And indeed, again, you can see there is no degradation response or reduction in cell viability. The third and final category are mutations that have an intermediate effect. These mutations, shown here in these 3D models, occur in amino acids that are predicted to be critical for the proper folding and stabilization required for active cereblon. The common element between these 4 mutations is that there is a differential response between IMiDs and cell modes, and mezigdomide in particular was able to elicit a cell viability response in every case. For example, here, this mutation at amino acid 326 appeared to induce resistance to IMiDs with much reduced cell viability response to them, with much reduced cell viability response and neosubstrate degradation. However, we can see here that cell modes still induce neosubstrate degradation and reduction in cell viability, albeit to a lesser extent than seen with wild-type cereblon. The mutated molecule here is near a zinc binding site, and any alterations here are expected to impede the proper folding and stabilization required for active cereblon. However, this appears to have been overcome with cell modes. In order to further validate our results, we performed dynamic modeling where we stimulated the interaction between cereblon, lenalidomide, and Icaros, the neosubstrate, for 100 nanoseconds to observe their interactions in time. This is the result of that work, which clearly shows that the change of this proline to this serine results in physical clash of the structures that does not allow for the proper folding formation required for cereblon activity. And although we can't model yet the binding of mezigdomide in such a manner, due to the lack of a reliable crystal structure, it is our hypothesis that mezigdomide, by bridging the amino and carboxy terminals in cereblon, it's forcing it into its closed active conformation, and even if that occurs to a small proportion of cereblon complexes, it is still sufficient to induce a degradation response and myeloma cell death. This may make the use of cell modes in patients whose myeloma harbors these mutations viable even after the development of IMiD resistance. In summary, we identified 3 different types of patterns of response to IMiDs and cell modes with mutations at different sites in cereblon. Here, the mutations that appear to leave cereblon active for both IMiDs and cell modes, mutations that interfere with structural elements leading to IMiD resistance, yet activity is retained with cell modes, and then mutations that lead to no response to IMiDs or cell modes, and those are the ones that are predicted to lead to collapse of the tritryptophan pocket. These results may have important implications for the interpretation of cereblon sequencing results from patients for future therapy decisions, particularly differentiating for those who may, despite relapsing on IMiDs with cereblon mutations, have the potential to still benefit from the use of CELMoD agents. And I'd like to finish by thanking the other members of our team, our founders, and the UK Myeloma Society and GSK for supporting our research. Thank you for your attention.
Questions from within the room? Gui.
Thank you. Very nice talk. Very nice work. Do you? But if one were to try and use to try and design a biomarker to select patients for treatment with, say, lenalidomide or mezigdomide, I know you can stain bone marrow biopsies for cereblon, and you can measure protein levels of cereblon. Do you have any idea, any information on whether this mutation changes the epitopes that antibodies bind to?
Unfortunately not, because these are single nucleotide missense mutations. Usually the antibodies will still probably bind anyway. So this would only be usable after sequencing results, ideally.
So staining wouldn't help, no?
Probably not.
Okay, well, thank you very much. Oh, sorry, Niels.
Very nice work indeed.
Thank you.
Maybe two questions, if I may.
Of course.
Have you already looked at samples post-LEN, post-POM, post-IBR, post-MESI, and do you see an accumulation of what the mutations that you predict to be seeing?
So these are not mutations that we predict. These are mutations that have been seen in patients post-treatment. Unfortunately, most of them have been seen once or twice because we don't have a lot of sequencing data from patients, but these have appeared post-treatment, usually with LEN and POM, as we don't have any data for MESI.
Okay, you didn't look at the samples post-IBR, post-MESI to see whether you see an increased rate of such?
No, there isn't enough sequencing of patients yet.
And the second question is, well, IMiD CELMoDs have also immune-mediated effects. So do you think that cereblon mutations might also occur in healthy immune cells because of all the pressure that you give, or this has never been seen in your data set?
This is what we are currently working on. So I guess, moving on from myeloma cells as they are and taking patient samples and isolating immune cells to actually see the effects, but nothing has been established yet.
Okay, thank you.
Thank you.
That's great, thank you very much. Well done.
So now I'd like to introduce our second abstract winner. This is going to be an online talk, but then our speaker will join us for questions at the end. So this is a presentation by Dr. Gaurav Agarwal. He is an academic junior doctor who graduated from Oxford Medical School in 2021. There he developed an interest in using genomics to define blood cancer risk. He then completed an academic foundation program in Oxford under the mentorship of Karthik Ramasamy and Sarah Gooding, during which he led a pilot study to implement a targeted sequencing panel for newly diagnosed myeloma patients. He's now working under the Kennedy Scholarship and completing a master's in computational biology at Harvard University, and he's a research fellow at the Broad Institute investigating inherited mechanisms of blood cancer risk. Fortunately for us, he plans to return to the UK to complete his clinical training next year and pursue a career in academic hematology. So hopefully we have his talk.
Hello everyone, my name's Gaurav Agarwal. I'm sorry I can't be here to present this work in person today, but I'm excited to share work we've been doing at the Oxford Translational Myeloma Centre, in which we've been piloting the implementation of a targeted sequencing panel for newly diagnosed myeloma patients. The background to this work is that there remains a subset of high-risk myeloma patients who do poorly. Often these patients are only realised to have been high risk in retrospect and may have warranted more intense frontline therapy. There is a need to identify these patients at diagnosis so they can be treated separately to improve outcomes. Now, a variety of approaches have been used to identify high-risk patients, including FISH and the Sky92 gene expression panel. There is therefore the opportunity to continue to refine this to improve diagnostics and to better treat myeloma at diagnosis. At the genomic level, there exists a variety of methods that could be used to identify high-risk markers. Whole genome or exome sequencing would capture nearly all variants, but this remains expensive and requires significant time and resources for interpretation and are hard to scale. There is the opportunity to capture the most important myeloma-specific regions in a more focused method through targeted sequencing. This has the advantage of being more cost-effective and scalable with potentially greater sequencing depth. Recently, the Myeloma Genome Project, or MGP, targeted sequencing panel was created as a collaboration between Oxford and Indiana University and scientists at Bristol Myers Squibb. The schematic highlights that the MGP panel captures almost 300 loci that are recurrently mutated in myeloma. Precise FISH probes vary between centres, but for comparison the yellow stars highlight only a handful of regions that are currently captured by FISH under UK reimbursement. During development, the technical performance of the MGP panel was benchmarked against whole genome sequencing. Importantly, some of these markers, such as MYC rearrangements, may have prognostic value and are currently missed by FISH. In the current study, we aim to explore the potential clinical utility of the MGP panel. We did a head-to-head comparison with FISH in newly diagnosed myeloma patients. Our goals were to conduct a pilot study to implement its use within the existing framework of a National Health Service lab in the UK. We were interested in how the extra resolution afforded by the panel would alter risk stratification and treatment decisions at diagnosis. Our pilot study included 46 newly diagnosed myeloma patients. We did knowingly pre-select some patients who were classified as standard risk at diagnosis, but we know did poorly. Each patient had both FISH and the MGP panel attempted from their diagnostic bone marrow aspirates. We found that the MGP panel had a greater rate of successful reporting. Around 20% of patients do not have FISH reported due to technical failure, but in comparison, the panel failed to be reported for just 1 of 46 patients. To assess how this would alter treatment decisions, we conducted a simulated MDT meeting. This was composed of 10 consultant haematologists who specialised in myeloma, and all were blinded from each other. The MDT were presented with each of the 46 patients' cases twice, once with the FISH report and once with the MGP panel, but cases were randomised to avoid recall bias. As expected, we found that the MGP panel captures many more genomic markers than FISH. The MGP panel reported nearly all variants detected by FISH, and additionally reported equivalent loci at greater resolution. For example, the MGP panel caught subclonal copy number changes, including 1Q gain in an additional 5% of patients, and 17p loss in 17%, that were missed by FISH. In other cases, the MGP panel highlighted prognostic loci not captured by FISH altogether, such as MYC rearrangements in 35% of patients. In the simulated MDT, basic clinical details were provided for patients, based on what was known at the time of diagnosis. The right panel displayed either FISH or MGP panel report. In cases where FISH or the MGP panel failed, the right panel simply stated that the test failed, as would be observed in clinical practice. This is an example of a case with FISH. The clinicians would also have seen the same patient again with the MGP panel report instead, as shown. The MGP panel report summarised the single nucleotide variants, the copy number changes, and translocations captured by the panel. This is a case of a patient who had a normal FISH report, but where the MGP panel was able to identify a MYC translocation, for example. Each MDT panelist were asked the same set of questions for each case. Clinicians had to designate the patient as standard or high risk, and were asked whether they would opt for an intensified regimen if available. If there were therapeutically actionable variants, as per the MyDrug trial, panelists were additionally asked whether they would consider prescribing these in addition to standard induction therapy, if available. For transplant-eligible patients, clinicians were asked to choose between single or tandem transplant, and as for all patients, whether they would continue maintenance therapy for a fixed duration or continuously to relapse. For each case, we took the consensus majority MDT view shared by more than 50% of panelists for each of these decisions and compared consensus decisions between FISH and the MGP panel. Our pilot study found that the MGP panel altered clinician risk designation. With FISH, the MDT classified 13 patients as high risk, but with the MGP panel, the same clinicians reclassified an additional 13 patients from standard to high risk. We then looked at these upclassified patients and asked what were their associated genomic features revealed by the MGP panel. These patients were enriched for prognostically significant copy number changes and MIC events. Therefore, the additional genomic resolution available through the panel can identify prognostic markers that are associated with changes in clinician-led risk stratification at diagnosis. Next, we considered how treatment decisions changed with the addition of the panel information. We found that 24% of patients were reclassified from a standard to an intensified regimen of induction chemotherapy with the panel. Of 25 patients who were transplant eligible, an extra 3 patients, or 12% overall, were reclassified to receive a tandem autologous transplant with the panel. Our pilot study therefore finds that the MGP panel may enable risk-adapted tailoring of the initial treatment pathway for newly diagnosed patients. Finally, we found that the MGP panel highlights variants that may be therapeutically actionable. There is the ongoing MyDrug trial, which is piloting whether existing targeted therapies can be repurposed for specific variants in myeloma patients. We assessed whether patients had any one of these 4 variants, which would qualify them for a targeted therapy. In eligible cases, clinicians were asked whether they would consider a targeted agent in addition to standard induction therapy. Clinicians stated that they would have considered a targeted agent in the majority of cases if the option were accessible. So we find that the MGP panel has the potential to highlight novel actionable therapeutic insights. Our next steps are threefold. Firstly, we plan to roll out the MGP panel to profile all newly diagnosed myeloma patients locally. Secondly, we plan to use the RADAR trial of FISH-directed treatment intensification to do a head-to-head comparison between FISH and the MGP panel in a much larger and unbiased cohort. Thirdly, we envisage building an observational registry where the MGP panel is integrated for all UK myeloma patients. In summary, we did a head-to-head comparison between FISH and the MGP panel, finding that the panel has a higher technical success rate and that it reports several prognostically significant variants that are currently missed by FISH. At a similar price, we believe that the panel offers potential to empower clinicians to tailor clinical decision-making for newly diagnosed patients. This work has been highly collaborative across centres, so I'd like to thank all involved and our collaborators. Thank you very much for listening, and I'll gladly take any questions.
Okay, so we're just waiting. Gaurav, are you with us online? Hope so. I have a question. Yes, here he is. Hi, Gaurav. Welcome to UKMS. And thank you very much for your excellent talk, which we've just enjoyed.
Thank you.
Thanks. So I have a question about sample quality and how much that is important in success rate of this technique. Do you think it's something that could be widely applicable in the UK? I assume because you can go back and use retrospective samples from myeloma 15, it's not that hard, but can you comment on that versus FISH, which we all know is fraught with difficulties?
Yes, we did have a higher technical success rate with the panel. These were samples which were between 3 and 4 years old that were biovamped, so from about 2019 to 2020. And they performed well, so we'd envisage that this would have high success rate in radar samples, for example.
And how much material do you need? And is it DNA only, or do you need RNA as well?
So this is DNA only,
Yeah.
and exact quantities I don't have off the top of my head,
Okay.
but we managed to have enough for all the patients that we wanted to profile.
Great. Okay, any further questions in the room? Kui has a question. So Professor Kui Yong from UCL.
Hi, Gara. Very nice talk. I wanted to pick up on the issue of using targeted treatment. This is out of the scope of your abstract, of course, but where would you envisage in the treatment pathway one would use these agents? And would they be different depending on what the target was?
Yeah, that's a really good question. We asked the panelists whether they would include them at diagnosis, and in addition to any standard induction therapy they would have used anyway. So not used as a replacement. In terms of where in the pathway, I don't have a clear sense because I'm not a myeloma clinician myself, but I think it'd be really interesting to explore that in future work.
Thank you.
Great. Okay, we've got a question from the online audience. So the questioner says, it makes one feel very uneasy not to have fish at diagnosis for young patients. Is this a viable alternative, and how long before it's routinely available? Along the lines of what I was asking.
So we hope it's not too long before it might be available. It's at a similar price to fish. So there's the question of what we can do with all the extra information, and clearly one of the limitations is there's a lot that we need to still understand about what is prognostic and what is not. But at the very least, having an assay which might have a higher technical success rate may be really good for these younger patients, as the person mentions. But we do need to do further work in larger sample sizes and to fully do a head-to-head comparison in a less biased cohort.
Sure. Okay, great. Any further questions? Yeah, we have one at the back.
Hi, I was just wondering whether in the future it would be possible for this to be used as a blood test as opposed to requiring a bone marrow sample?
Potentially. I think, as far as I'm aware, there is a field looking at trying to ascertain these myeloma mutations from peripheral blood through liquid biopsy. I think there are a lot of technical challenges still in the current stage of that, although it would be lucrative to be able to do that in the future.
Yeah, I guess it would depend on the sort of density of circulating tumour cells. Any further questions? No? Okay. Well, once again, thank you for your excellent talk. Thank you for joining us online for comments. And that would conclude the ASH bursaries section. We have run a little bit over time. We were planned to rejoin at 1:25. We can extend that to 1:30, I'm told, so please be back by 1:30 for our Michael Morley speaker. Thank you.
That's good. Really interesting. We managed to cover up for changes in the plan really smoothly.
Yeah.